Okay, let's get started. Welcome to the Musella Foundation's webinar series. Today's topic is a promising new targeted radiation therapy for leptomeningeal metastases in breast cancer, lung cancer, and other malignancies. An introduction. And our guest speaker is Dr. Andrew Brenner, who's a professor of medicine, neurology, and neurosurgery at the University of Texas Health Science Center at San Antonio. Welcome, Dr. Brenner.
Thank you. It's a pleasure to be here with y'all. I appreciate the opportunity to kind of go through this clinical trial that we developed at our institution and has since been funded by the Cancer Prevention Research Institute of Texas and is being also developed by Plus Therapeutics. So I always like to start off with a blurb about why we do these clinical trials. And the clinical trials are very important because they help us to translate our results in terms of our basic science into ways to better prevent, diagnose, and to treat cancer. The more people that take part in these clinical trials, the faster that we can answer all of these critical research questions and find better treatments and ways to prevent cancer. Unfortunately, only about 3% of adults with cancer participate in clinical trials. So the more that we can do to encourage clinical trial participation, the faster we can make developments and the faster we can improve outcomes for our patients. So today we're talking about leptomeningeal metastases. What are these? Leptomeningeal metastases is when cancer spreads from whatever its normal site is to the spinal fluid that surrounds the brain and spinal cord. It can be from any type of cancer, but the most common types of cancer are breast, lung, melanoma, and gastrointestinal cancers. It's diagnosed about 5% of patients with metastatic cancer and affects about 110,000 people per year in the United States. And it causes debilitating neurological symptoms and eventually loss of life. Just to kind of go over the anatomy, as you see here in this picture, below the skull, there is a very thick layer that's really stuck up against the skull called the dura. And then below that, you have a thinner layer called the arachnoid. And then the arachnoid has below it the spinal fluid, as well as the blood vessels and some very fine other matter. And then there's a very, very thin layer. It's almost like if you peeled that layer away from an onion, you could see through it. That's kind of what the pia mater is. And it is stuck right up against against the surface of the brain. And so with the spinal fluid is actually generated within the ventricles and circulates around the brain and around the spinal cord. So when cancer gets into the space and starts to grow there, it causes significant neurologic dysfunction because the neurons are right below this area, the body of the neurons. And so it can cause such bad dysfunction that patients have what we call encephalopathy, where they have confusion. It can coat the cranial nerves and cause specific cranial nerves not to function, like the facial nerve, resulting in facial paralysis. One of the oculomotor nerves causing the eyes not to move together with each other. The nerves to the tongue and pharynx, which can cause people not to be able to swallow well. So it can be really quite debilitating. The typical treatment strategies we use are to maximize the use of therapies that we know cross into the CSF and into the brain. And that depends on the type of cancer. For breast cancer, for example, we have a few agents like capecitabine, also known as Zolota. We have carboplatin. We also can use that for lung cancer, and we can use small molecule inhibitors in certain cases of lung cancer. That helps some, but ultimately cancer tends to regrow despite these. We also can do what we call neuroaxis directed therapies, where we treat directly in the brain and spinal cord. This can be external beam radiation, where we use radiation beams to converge at the site that we're treating, or we can give chemotherapies directly into the spinal fluid to circumvent the blood-brain barrier. So we are instilling it in there, and then it can treat the spinal fluid directly. In terms of problems with this, we stopped using what's called craniospinal radiation, which actually actually, treats all of the brain and all of the spinal cord. And so you can imagine that you're not really sparing any part of the brain. And with that, patients can have significant toxicity. And there's a lot of surrounding structures right in front of the spinal cord. You have the esophagus, you have the stomach, you have the gut. And so patients can develop issues with any one of those structures when you do that. And because of that, we kind of moved away from that and started focusing more on what's called involved field radiation, where we're just treating a spot, the part that is causing the patient to be most symptomatic. There is no survival benefit associated with that. That is purely what we call palliative treatment to reduce symptoms. More recently, there has been the use of proton beam radiation, which instead of using X-rays, you use these heavier proton particles, and so they can stop much shorter. So you do minimize some of the toxicity of craniospinal radiation with that. That is something that just recently that the data is suggesting that may have a survival benefit for these patients, but that still requires some confirmation in larger studies, but it's looking very promising. The patients that developed these metastases have a poor prognosis, and anywhere from 3 to about 6 months in general, whether you're talking about breast cancer, lung cancer, or melanoma. So what we're looking for is a way of redefining the radiation that we're doing in a manner that, number one, is convenient to the patient. Because a patient who's going through treatment for leptomeningeal disease is already dealing with a lot of healthcare burden. We need something that would be more effective than what we have currently and more precise, because we want to reduce the toxicity. And that means targeting the tumor, the cancer cells, but not targeting the normal healthy tissue. And our ultimate goal with this is to improve the quality of life and to extend life, to make people live longer. To do this, we're using a new type of therapeutic that is called RNL. That stands for rhenium nanoliposomes. We have first developed this for treating primary brain tumors, glioblastoma, and now have moved into treating leptomeningeal disease. Rhenium-186 is a very interesting isotope. It is a rare compound. It's very inert. It's a rare metal and is used in precious alloys. For example, it's something that they add into jet engine blades because it has a very inert characteristics. Is not chemically reactive in any way. This particular type of rhenium that we're using, rhenium-186, it exerts what's called a beta particle, which is heavier than an electron. It's a positron, and it shoots only a distance of around 2 millimeters. So if you think about 2 millimeters, you're thinking about like maybe 2 pencil leads deep. That's as far as it'll go. And so we can really exert control with it as opposed to X-rays or protons. It needs a carrier. In other words, if you administer this type of radiation into any tissue, it's just taken up and carried away. Okay, so it doesn't stick there long enough in order to do anything. So you need a way of trapping it into the tissues. So we use liposomes for that. We've been using liposomes for many years for chemotherapy. For example, we have a drug called doxorubicin that we use for breast cancer and sarcomas. And we started encapsulating that into these liposomes, these little fat bubbles, many years ago. And that changed the toxicity of those medicines so that they could be given repeatedly and without causing the same problems to the heart and other tissues. And so liposomal encapsulation, or in other words, trapping things in these little kind of lipid bubbles, these little fat bubbles, really changes the way that they're processed by the body. And so to do this, we developed a specific molecule called BMEDA. But the important point about that is that that is a unique way of getting that rhenium into the liposomes very densely, so that the liposomes are very heavily loaded with radiation. And then we can administer that into the tumor site and get it to stay there. It also helps with the dispersion of it. So it offers the potential to increase the amount that we give, but without increasing the toxicity, because it's really confined to a very narrow window. And so there's the term we use for that is a therapeutic window, which is the amount of space we have between an effective dose and a toxic dose. For some types of treatments, it's a very narrow window. In other words, you have to get right up near the toxic dose in order to have effectiveness. What we want is we want to have a very large window in terms of safety, so that we can get up into these higher doses and have more room to exert better control of the tumor. And we think we can do that with this. In our laboratory, we first started using this in rats that did not have tumors to see how much they could tolerate. We injected this directly into the ventricle, and I'll explain the ventricle in a second, but the ventricle is where the spinal fluid is made. And so we injected into that, and we could see it distribute all along the brain and spine. And you can see the images down below. This is next to the rat. Here is a little tube where we put a sample of the radiation, so we could use it as a comparator. And then on the left in each one of these images is the rat, and you can see it's going up and down the spine here, with more of it along the brain. And so we saw that it was retained out in the brain and spinal cord out to 48 hours. And we didn't really see any toxicity. We gave up to a dose that would be absorbed that's equivalent to 1,075 gray. By comparison, when we treat patients with brain metastases, we use 30 gray, 30. So we're talking more than 30-fold the typical dose we would use to help palliate a patient with this disease. These rats did not really experience any significant toxicity. They lost about 1 or 2 grams of weight in the first week and gained it back in the second, third, and fourth week with no problem. By comparison, they weigh 150 grams. So you can see that really that's not anything significant for these rats. They didn't develop any neurological symptoms whatsoever. They seemed to do just fine. And they kept eating and drinking and doing everything that they needed to do. When we looked at the area where we injected it, all we saw is a little bit of kind of a mild scar tissue, but nothing else. No significant evidence of injury. When we went back and looked at animals that had breast cancer spread to the leptomeningeal, where we inject the cancer directly into the ventricles and allow it to spread and then treat afterwards, we saw improved survival both with a glioma model, a glioblastoma leptomeningeal model, as well as a breast cancer leptomeningeal model. So in both cases, we seem to help animals live longer. Based on that, we developed a clinical protocol, sent it to the FDA for their approval, and have since started a multi-center clinical trial. It's considered phase 1, even though we have explored these doses in patients with primary brain tumors, because it's a new site that we're treating within the leptomeningeal. We start all over in terms of safety data. So we're exploring dose levels when we administer directly into the ventricle, even though we've already explored much higher dose levels in patients with primary brain tumors. The goal of this is to determine the maximum tolerated dose, how much we can give before we see any signs of toxicity. We might not ever reach that. In the glioblastoma trial, we had not reached that, and so we're moving forward with doses based on efficacy rather than on toxicity signals. And so these patients will all get the RNL directly into the ventricle. Right now, we are open at UT Health San Antonio at my institution, as well as UT Southwestern Medical School, where is Dr. Yusuf's institution. And we have other sites coming, including Northwestern, where Dr. Kumthekar is going to be the principal investigator. That's in Chicago. We are pending at Massachusetts General Hospital, where Dr. Brastianos and Dr. Wang would lead the study there. And we're also looking at Colorado, Stanford, and another site in the East Coast. The eligibility for this, patients have to have leptomeningeal disease. And we kind of classify these as type 1 and type 2, which really is, do you have cells that you can see floating around in there that you can quantify? Yes or no, type 1, type 2. And then by the radiographic signature, whether we see just a lining of it on the MRI, or we see big nodules of it on the MRI, et cetera. Patients have to be of reasonable performance status. What that means is they have to be healthy enough. They have to be able to do basic activities. This is very standard for clinical trials. We don't want to take somebody who's really not very fit and give them something that we're investigating, because there is potential for more harm than good. They need to have healthy kidneys, healthy liver, healthy lungs, etc. Right now, we don't want to have anybody that has obstructive or symptomatic communicating hydrocephalus. In other words, if their spinal fluid is not flowing, those patients are not a candidate unless they have, they're no longer symptomatic and they have a shunt in place. If they have a shunt, it has to be programmable, so we could be able to turn it off after we inject in the treatment. And they have to have no contraindications to placement of an Ommaya reservoir. I'll explain what Ommaya reservoir is in a second, which is really important to understand the treatment. Patients who had any dose to spinal cord or whole brain radiation are not considered eligible. This is a safety measure that the FDA requested of us until we get more safety data. We're hoping to get rid of this now that we're moving forward with the safety data, that maybe after the first 9 patients, that will no longer be a restriction, but for right now it is. And then standard concomitant illness restrictions, which means that you can't have any kind of life-threatening illness at the time besides your cancer. So this is the Ommaya reservoir in this picture on the right. So what it is if you know any cancer patients, they have something called a mediport that sits on their chest wall and has a catheter that goes into the big vein. This is not unlike that. It's like a little drum, and that's a membrane that a needle can go into. Directly below that, there is a catheter that goes all the way down into the ventricle. The ventricle is in the middle of the brain. There's 2 what are called lateral ventricles, one on the left, one on the right. And then there's the 3rd ventricle right below it, and then the 4th ventricle along the brain. And then the spinal fluid circulates around the surfaces of the brain. It is all made in these lateral ventricles, the spinal fluid. There is a little structure, kind of worm-like, sitting on the bottom of the ventricle called the choroid plexus. That's what makes the spinal fluid. So this catheter goes all the way down into this ventricle, and then the chemotherapy is injected directly into that ventricle. So then the spinal fluid, which circulates about 5 times a day, will be able to carry that around. Because of the liposomes, it should stick to the surfaces there and radiate that area. After we put the Ommaya reservoir in, we check to make sure they have good flow. And then after they have good flow, then we put the radiation treatment in. And then we just do imaging and blood collection and a spinal fluid collection after that. So it's a single treatment, one treatment at the very beginning, and then everything else is imaging. These are the patients we have enrolled to date. We've enrolled 4, 2 men, 2 women. One had a small cell carcinoma, which is a very aggressive type of cancer. 2 had triple negative breast cancer, and 1 had lung cancer. The doses that we are administering, we're starting with what we think is going to be around 50 gray. I'll show you that data. And then we're dose doubling each level thereafter. For the first 4 patients we treated, thus far, we're seeing no treatment-related adverse effects, more than grade 1, which means very mild in character. The most common symptom was headache, which I think that was really, we learned a little bit from this. We were giving patients something called supersaturated potassium. So we gave them a potassium drink to avoid exposure of their thyroid gland, but that can cause some nausea. And then when you give nausea medicine, that can cause headache. So we think it was more a factor of that than the actual treatment, but we can't eliminate the treatment as a possibility. But our first patient had no adverse effects. Our 4th patient had no treatment-related adverse effects. Our first patient, as I mentioned, the potassium iodide, patient 101, our second patient had, as I mentioned, the potassium iodide caused some nausea and then took the nausea pill and some headaches. And our third patient also had some intermittent headaches, but nothing really major. This is our first patient. Again, a 70-year-old gentleman who had small cell carcinoma of the right oropharynx, who had metastases in the brain and spinal cord. And he received the RNL a month after his diagnosis. And you can see what's called the SPECT-CT imaging in the bottom left corner. And that shows the distribution of the radiotherapy after it's administered. So as expected, about right after the administration is done, you see it in the lateral ventricles. It's in the middle of the brain. That's where you'd expect it to be. But 24 hours later, it's cleared out of the ventricles and it's all along the surfaces of the brain, okay? Here as well. So really what we would expect in terms of distribution. In terms of the amount of radiation that was absorbed to the ventricles and the surfaces of the brain, we saw about 29 gray. To the ventricles, about 14 gray, because it does clear out of the ventricles relatively quickly. To the just to the surfaces of the brain alone, around 37 gray, and just the spinal fluid around 9 gray. This shows this patient's distribution of the drug. You can see about 15 minutes after the administration, this little dot next to the patient is just a little sample of the radiation, so we can use it as a comparison in terms of the amount of radiation we're seeing, because we can put a known amount in the tube and image it with the patient. And just as expected, we see it along the midline, really in the ventricles, about 15 minutes, starting to spread into the spine and not yet making it around the brain. 3.5 hours later, more along the spine, more along the surfaces of the brain, but not all the way around. 24 hours later, all the surface of the brain looks like it's exposed, still along the spinal cord. 48 hours later, more of the same, and then 7 days later, all along the surfaces of the brain. So it is really being retained along the surfaces of the brain out to 7 days. So it's getting where we need it to and staying there. In this particular patient, you can see what we saw here in terms of cell count. Before we started treating him, his cell count was 71 cancer cells per milliliter, and then it dropped down as low as 6 within 48 hours. So a 90% drop within 48 hours. It stayed there for a full month. Then it started coming up, unfortunately, and 56 days later, it had more than doubled. So we got some temporary control, not long-term control, but there's two important things to note about this. Number one, this is a very aggressive type of cancer, small cell cancer. And number two, this was the very first dose we administered, the lowest dose we administered. And we have yet to administer the highest dose that we plan to administer. Next patient was a 59-year-old female who had a right upper quadrant breast cancer diagnosed many years ago. Unfortunately, it came back in the 9th of April, 2018, and then developed leptomeningeal metastases on the 2nd of November, 2018. She did well after a treatment with high-dose methotrexate and was doing great, and then received immunotherapy, and she was back to her baseline for a while, but then unfortunately, she started to develop recurrence. At that point, she enrolled in the clinical trial, and shortly after her diagnosis was treated with the RNL on the 27th of April of this year. Again, you see very similar imaging along the midline and the ventricles early on, and then 3.5 hours later, it started to distribute around the surface of the brain.
Wait a second, Dr. Brenner.
Yes.
Quick question that applies to this slide, so I want to ask now. What absorbed radiation dose do you think is needed to control a tumor?
Well, we use typically for a patient with metastatic cancer, 30 gray is typical in terms of what is administered, but that's because that is the maximum safe dose. When we treat, for example, primary brain tumors, where we're just treating a spot, we go as high as 60 gray. We do not know with this radiation the amount that would result in a long-term remission of the cancer. So it's kind of relative. We know that these doses that we're administering are very, very similar, even though they're our first doses, our first dose level, they're very similar to what we use in the palliative setting. Does that answer your question?
Yes.
So, and you can see her exposures here along the cranial subarachnoid space, around 25 gray, to the ventricles and subarachnoid space, a little bit less, around 19. There's our imaging after treatment, again, along the ventricles mainly, then around, then it starts to spread along surfaces of the brain and remains there. This is her cell count. You can see pre-treatment, she was 86. We saw there was an increase initially, which is kind of perplexing. I think it's maybe mobilization of cells off the surfaces. I'm not totally sure. But they did go up initially, but by 48 hours, just like we saw in the next patient, a significant reduction. So she had 80% decrease by 48 hours, and then she's kind of hovered around 31 cells. As a matter of fact, she is now another, I guess, another 56 days out, and she is remaining, I think her cell count is still lower than this, actually. Certainly no higher than 31. It's staying low. So she's had some good control of her disease from being treated back on April 2018 and just followed up a couple weeks ago and doing very well. Our next patient is a 60-year-old with lobular breast cancer who was diagnosed back in 2016 and then was found to have metastases in 2020, mainly involving the bone. And then in January, she presented at the hospital with some very significant neurologic symptoms, was found to have leptomeningeal metastases. We treated her with high-dose methotrexate. We got an initial response. She seemed to be doing better with a reduction in her cell counts, but then we had to stop it because we were worried she was developing toxicity from it after about 5 doses. So we stopped it and put her on observation, but unfortunately her cell counts were starting to come up and she was starting to be symptomatic. So we treated her with RNL on the 15th of June, very similar imaging to the last 2 patients. The dose to the ventricles and cranial subarachnoid space is around 27 gray, and to the cranial subarachnoid space around 20 gray. Again, the retaining along the surface of the brain. And she had initial cell counts of 839 pre-treatment, which dropped down to 396 by day 28, but started rising around day 56 again and went on to other therapy. Our next patient at the next dose level, where we now doubled the dose level, is a 55-year-old who has lung cancer that was treated with RNL on the 31st of August. This is where he is. He's kind of bouncing around a little bit, but pre-treatment his cell count was 52, but we're seeing some control. Here's his imaging, and we're only out to 28 days so far on him. There's his imaging. Again, just kind of turning it up a little bit. And this is really nice because this shows it in 3 dimensions. So you can see immediately after injection within the lateral ventricle there, just on one side, right after injection. Okay, it hasn't spread to the other ventricle yet. And then 24 hours later, you can see it around all the surfaces of the brain there and down the spinal cord. So in preclinical studies, we were able to administer over 1,000 gray without any toxicity and a significant survival benefit. In our phase 1 trial thus far, it's administered as single treatment. It's very quick. Patient has the Ommaya reservoir, which is an outpatient procedure. Usually that's done by a neurosurgeon in under an hour to put it in, and they go home the same day. When they come in for treatment, the treatment literally takes us 5 minutes to inject it. Now, there's a lot of imaging and stuff like that, but it's all done outpatient. We've seen absorbed doses of anywhere from 18.7 to 29 gray. just in these first cohorts, but we are going to significantly increase our doses and hope that it's going to mimic what we've seen in the glioblastoma trial, as well as in our animal studies, where we can go significantly higher in our doses. It distributes around the brain and spinal cord and stays there for at least a week. All 4 patients experienced a decreased tumor cell count following treatment, and we're continuing to dose escalate. So 186RNL is a targeted radiotherapeutic and holds promise for patients with leptomeningeal metastases from solid tumors. I mentioned that we're adding additional sites. Hopefully those will be up soon. Our goal is to complete phase 1, part 1. We'll have to see how many different dose escalations we'll need to do. As many as 21 patients possibly, but if we end up seeing something along the way, we might even be able to use less patients. And then to start the part 2, which is or phase 2, which is to evaluate the efficacy in a cohort of 20 breast cancer patients and 20 lung cancer patients. And with that, I'll stop and take any further questions.
Thank you. It was very informative. There's a couple of questions here. First, on a few of those patients, they did great for a while, and then like day 50, 60, they started tailing back up. Can you repeat the injection at that time?
That's the goal. So we're still learning about it. And so for right now, we're giving it a single administration and learning about, number one, when would you want to re-give it, right? So we have to gather that data first from our experience, because we have never used this before. So if we see that even with higher doses, that we want to repeat it at 3 months or 4 months or who knows, then we will go back once we have the safety data for those doses. But the question might be, do you need to repeat it if you double or triple the dose or quadruple the dose? If you quadruple the dose, maybe you eradicate it completely. Maybe it lasts a year. So we first have to get that data. And then we can explore repeated dosing. And maybe it'll be twice a year, maybe it'll be 3 times a year, I'm not sure. The management of these patients right now is really important to keep in mind. When we do intraventricular therapy with methotrexate or cytarabine, we do it twice a week for at least 2 months. And then we go weekly for like a month, and then we'll put them on surveillance where we're checking their CSF. So even when it works, the burden on the patient is really high because they're constantly coming in to get this. They have to come into the clinic at least twice a week. Plus, a lot of times they're also on systemic therapy. They're also getting something like capecitabine or something like that. So even if we have to repeat it, if that ends up being necessary, that should be fine. It's still going to be a dramatic improvement in terms of quality of life over what we're doing currently.
How about eventually combining those 2 treatments? Do the old treatments plus this instead of.
So we actually are looking at it not in terms of traditional chemotherapies, but with some more novel things. So what we are looking at is, number one, immunotherapy, combining it with immunotherapy. There's really good data that is emerging. Priscilla Brastianos and Nancy Lin and Yudosha Lee and a few other investigators are showing really good data for both pembrolizumab and nivolumab for patients with leptomeningeal disease. So it's really promising. Now, those are improvements of months, month or two. They're not dramatic, but it's showing that it's doing something. And there is a lot of data with combining radiation and immunotherapy. And so we feel strongly that that would actually be a reasonable combination to look at, and we're looking at that in our preclinical models. Once we know our dose and what we're seeing, right, then it would be to add in the immunotherapy, right? The other thing we're looking at is DNA damaging agents, because we're actually collecting these cells and we're doing sequencing them and looking at what's going on in the cells as we do this study. And so that'll provide us important information, but we're also looking at various different DNA damage response pathways that we can inhibit, like PARP, DNA protein kinase. There are a few different ones. And so small molecule inhibitors have been developed for those. So if you can imagine, at the same time that you're giving radiation, inhibiting their DNA repair pathways, that you might give them a double whammy. And so we're looking at that as well, rather than looking at conventional chemotherapies, which probably won't move the needle as much. But those are actual interesting questions, and we are looking into those.
Okay. You talked about the CSF circulation circulates 5 times a day. Is that the same fluid recirculating 5 times a day, or does it get replenished 5 times a day?
It gets replenished. That's an excellent point. So it's made within the ventricles and then absorbed along the surface of the brain in these structures called arachnoid granulations. These arachnoid granulations kind of sit right next to the big veins. And so they kind of suck it up and filter it and put it into the blood flow. And so it's made in the ventricles, leaves the ventricular system, goes around the brain and spinal cord, and then gets reabsorbed. So you get 5 times a day fresh new CSF.
So if you inject this and then it goes out of the system within a fifth of a day, doesn't it take the drug out of the system too, or does it still stay there to keep recirculating?
That's the beautiful thing, is the liposomes cause it to be retained. So it's not just fluid.
Okay.
If we injected the radiation, that's exactly what would happen. If you injected the rhenium itself and not a liposomal encapsulated one, it'd get picked up and taken out. So you'd have a very short treatment. But the liposomes, we used to use a drug called Depocyte, liposomal cytarabine.
Right, they stopped making that.
They did, because it wasn't profitable, because they only had really approval for blood-borne leptomeningeal cancers. And it was an improvement, but it was not a dramatic improvement. And making a liposomal drug, once it becomes generic and there's to be competing and costs and stuff like that, it just wasn't profitable for them. But it did improve the amount of time that the chemotherapy was retained in the spinal fluid. So that was administered every 3 weeks as opposed to twice a week. Liposomal radiation is much different than non-liposomal radiation and is retained, as you can see on those images I showed.
Okay, that's good that you clarified that. I didn't understand that. The half-life of this drug is 90 hours. So does that mean you have to make a custom made for each patient in the hospital in like a nuclear reactor type thing? How do you make it?
So it is custom made for it's custom labeled for each patient. So the radiation is constantly being made in a nuclear reactor in Missouri called MER, and they just ship it to us, and we put it in the liposomes fresh each week for the patients that week. So the idea is that right now it's kind of custom made for that patient, but we can use it for 2 or 3 different patients at a time if we need to, if they're being treated the same week. So you do need fresh radiation each time. It's shipped from a reactor and then loaded into the liposomes.
Well, that's good. That means it could be done anywhere. I was thinking you might have to have a reactor on site, but you don't. It could be shipped from the central place.
Yeah, we can actually, even with the 96-hour half-life, we generate enough isotope that we can have enough leadway, right? So that we can even have some time for it to decay, radio label it. And then what we do is we know the decay. And as long as we know the treatment date, we load enough specific activity so that when it gets to the patient, they will have the prescribed dose.
Okay, that makes sense. Let me see what else. That's all of the official questions, but I have a strange other question.
Okay.
It's about clinical trials. You mentioned the problems of having all these clinical trials, and we were just talking about all these combinations. If you want to do a clinical trial of all the combinations you just mentioned, it's basically going to be impossible and take like 50 years, and they're never going to get done. We have an idea of a completely new system of doing these types of studies. I actually wrote a bill that's in Congress right now that would actually make this possible. But I don't even want to talk about that. I'm just talking about the concept of clinical trial. My concept is you have a team of experts such as yourself. You sit there thinking up all these possible combinations that you want to test. You make a whole bunch of plan options. And then instead of running a specific clinical trial of each option, we have a patient navigation program where we just hit on like 1,000th brain tumor patient. Our patient navigation program gives patients a list of options, and it could be like a clinical trial, it could be a standard treatment, but a lot of times it's a combination of very hard to get treatments, such as this. Like, we would love to take your drug and combine it with like the immunotherapy outside of a trial, which is really difficult. We've been successful in some cases of getting experimental therapies, and then you follow those patients remotely in a virtual trial as if they were in a real clinical trial. You can basically collect the right amount of data, because you really got to know what the side effects are, how long they lived, and follow the scans. That doesn't have to be within a clinical trial, especially when you get into high numbers.
Yeah,
And the
I think.
plan, well, let me just finish this one last plan. The last part of the plan is the law that we have would require all the patients who use these drugs to be followed in the virtual clinical trial. So you wouldn't be able to get these drugs unless you're followed in a virtual clinical trial. So instead of having 4% of the patients, or the adult patients in a clinical trial, it goes down to 100%. And then you could learn from every single patient so much quicker. The other part of the law is we would get an early conditional approval of these drugs after like an early phase 2 trial, just when you're showing that it's safe and you figure out the dose. And the conditional approval requires that you be followed in a virtual trial afterward. Every single patient who uses these drugs have to be followed in a virtual clinical trial. And you have a time period of about 6 years where you have to prove that it actually works, otherwise you'll lose it. What do you think of a system like that?
Well, I think we need to do something different, and I think that certainly sounds like a great idea. I think the constraints right now for investigators are the regulatory requirements. I mean, and not just for investigators. If you consider industry, in order to do a clinical trial, it's not just, I have a drug, I'm going to give it to the patient, and I'm going to keep notes. No, the amount of data keeping and all the costs involved with having somebody external from the sponsor and the investigator monitor it and make sure the data is perfect and everything for the FDA is very expensive and very time consuming. So a clinical trial, I think probably more of the cost of running a clinical trial is the cost of the clinical research organization that is administering, monitoring, doing all that stuff, than it is actually the investigator, the drug, or anything else. So because of the regulatory requirements, what the FDA is requiring in terms of safety data, how they want it documented, all this, the rigmarole that's around clinical trials, it is not cost effective. It is not efficient.
Exactly. Under our system,
and I think that sometimes we're not seeing the forest for the tree. Yeah,
exactly. Like, they don't need 100,000 pages of research on each individual patient. You just need the bottom line of the side effects.
Well, survival data is certainly survival data, and it's hard to
fake that or miss it.
Hard to fake that. Hard to get wrong.
And then also, once you're talking about a large number of patients, when you're talking about 100% of the possible patients, even if the data is a little fuzzy, you will see trends immediately. Yeah. And
I think
part of the bill is that you doctors would have access to the ongoing results, so you could see what's working, what's not, what was tried, if it was safe, if it wasn't safe. And I think we could take decades off of the search for the cure.
I would like to see that.
Okay.
In terms of taking decades off, I don't think anybody would argue that.
Well, no, we have people against it, believe it or not.
Yeah. Well, we need people getting help sooner and better help.
We have people who say phase 3 clinical trials is the only way to go forward. Whereas of the last 100 phase 3 trials, how many were successful for brain tumors?
Yes, I hear what you're saying. And I
think there was like 1 or 2.
I've been in this situation and discussions about drug development many times, and you're right, it is a very frustrating system.
Oh, we got two new questions. It's a good thing we wasted time. Not wasted, we used up time. The first one is, what were the results using it in glioblastoma?
So we just presented that at ESMO, and we saw for patients who received greater than 100 gray, we're routinely getting about 400 to 500 gray administered for these patients now. We use anywhere from 1 to 4 catheters, and we administer it all within one afternoon, about 3 or 4 hours to the tumor. And for patients who got more than 100 gray, we're seeing a significant improvement in survival relative to the people that got less than 100 gray. So as we moved up, we're seeing significant improvements in survival. Now, those are dose escalations, right? So now we're into our phase 2. We're starting our phase 2, and that will be against a historical control where everybody gets a prescribed dose. So of the 22 patients that have been treated to date for glioblastoma, results are looking very promising.
Oh, we should have led with that. That sounds good. Going back to historical controls, one of the parts of my program are we would use this registry as the control group, and it would be matched, not really historical, it's an artificial control group where each patient is matched on everything to the point where it should theoretically be as good or better than randomization. Like in some of the trials that were randomized, they later looked back and saw that like IDH was not even because they didn't know about IDH back then. Even going back further, they had different MGMT levels because they didn't know about it back then. That's back in the 90s. Whereas with the artificial control groups that we have available, if you have a registry of 100% of these patients, you would have a much better idea of how the patient would be doing if they didn't use the drug compared to with the drug, and more better research.
Yeah.
The second question is this drug available on compassionate use yet?
No, not yet, because it's still in phase 1, and usually compassionate use comes later when you have safety data.
Well,
So
for glioblastoma, you said you're in phase 2 already.
yeah, so for phase 2, we're just starting the phase 2, and I think there should be a compassionate access program, but we're just not there yet. Hopefully we'll be there soon.
Perfect. Okay, that's it. We used up all our time.
Yeah.
It was very informative, very good. Thank you very much.
You're welcome.
And
It's a pleasure being with you.
see you guys next time. Bye-bye.